Good morning, everybody. Thank you for attending the Healthicity Auditor Roundtable presentation today, How to Create a World-Class Audit Program. My name is Patrick Williams, and I will be our facilitator. A couple of items to mention before we begin. Today's webinar will be about 40 minutes, then followed by a Q&A session. Your line is muted, so if you have questions, please send them via the chat box or feel free to email your questions after the presentation. Please note there will not be any CEUs for today's webinar. Our presenters today are Deanne W. Tate, Joel W. Lippin, Dr. Lynn Myers, Stephanie Scott, and Thomasina L. Young. Ms. Tate is the Director of Coding Effectiveness for Bon Secours Health System, Inc. She has 19 years of experience in healthcare, with previous roles as a Senior Compliance Specialist for Carolinas Healthcare System and as a Regional Director for the American Academy of Professional Coders Physician Services Department. Dr. Lippin currently holds the position of Director of Medical Coding and Clinical Documentation at UCLA Health System. During his 2.5 years with UCLA, he has made significant changes to the department, including the implementation of productivity and quality measures with a transparency report distribution to each staff member. Dr. Myers was in private practice as a family physician for 20 years before moving into an administrative role for Texas Health Physicians Group. Dr. Myers is a certified coder and is certified in healthcare compliance. She works to help physicians improve their documentation in order to confidently support the levels of service and diagnoses reported for reimbursement and to allow electronic capture of clinical data for quality monitoring. Thomasina Young comes to us from the Rock and Roll of Fame state of Ohio. She's been working in healthcare for 30+ years. She has worked as a medical assistant, a coder, senior practice manager, auditing supervisor, HIMS physician practice coding educator, and currently holds a position as HIMS physician practice senior coding manager with Banner Health. Stephanie Scott is Healthicity's Vice President of Audit Services and has over 20 years experience in the healthcare industry. Stephanie has worked in a variety of settings. Prior to working with AAPC Physician Services, Stephanie worked for NextGen, a leading EHR software vendor, as a regulatory manager, leading a team of clinical designers in developing and maintaining clinical content as well as regulatory components in the EHR system. With that said, I'm going to turn the time over to Stephanie and our other presenters.
Thank you, Patrick, and a special thanks to all of our panelists and all of you that are joined us today. We are really excited to assemble such a prestige group of experts. At AAPC Audit Services, we often have members and organizations call us asking questions about how to develop a prestige audit program. We have identified 7 essential pieces that make up an ultimate audit program. We will be discussing each of these 7 pieces. So without further ado, let's just go ahead and jump in. There are many challenges to overcome when you're first developing an audit program. Dr. Myers, what were some of the hurdles you faced at Texas Health, and how did you mitigate these hurdles?
Thanks, Stephanie. So first, let me do a sound check. How do I sound?
Good.
Okay, great. And I want to say also that this is a great format for sharing amongst a number of different organizations. I note about 3 things that right off the top that are a challenge in developing the audit program for us. One was time in reviewing when the audit results come in. So important that we have a chance to look through the audits, make sure that we don't have any outstanding, there aren't any specific circumstances associated with that particular a manual aspect to reviewing audit results when they come in. The second was harmonizing our expectations with our auditors versus our educators. So our auditors are doing their work and then indicators going out. So harmonizing expectations among those two is oftentimes a challenge. So one of the ways we addressed that was having regular calls with our auditors so that we could stay on the same page. And the third thing is designing for our organization the consequences for not meeting audit targets. We realized that we really needed a strong and really clear policy that our operations people could point to when the physicians and other providers were looking at their audit results, so that when there were unmet expectations, the policy could be referenced and it would not put the operations people in a difficult position. So from our perspective, those are three things right off the top that were a hurdle for us.
Thank you, Dr. Myers. Those are some good examples of hurdles that we face. Thomasina, what hurdles at Banner Health did you face when you started to implement your audit program?
One, can you hear me?
We can hear you, Thomasina. Go ahead.
Thank you for having me as a panelist. Some of the challenges that we faced was one of the greatest ones is creating a database tool for tracking all of our chart reviews and the corresponding education. And that tool was to meet the needs of more than just the coding compliance education team, but key stakeholders and leadership as well to see the results. And the other area I would say is standardizing our method of auditing medical records, because we are across 7 states with different MACs and different guidance, and we have to be able to develop many times an internal method of how we're going to review records, which would result in a policy and procedure that we would follow as an organization, and timely review of the documentation. So those are some of the that we faced, and so we've set parameters as far as time frames of when a chart review is completed, the validation time, and then the providers get a chance to do a rebuttal as well, and then we schedule the corresponding education. So we're working it out. It's working pretty good.
Very good. How often do you find you have to revise those policies, the standardization policies that you created?
We have to revise those policies quite often, because many times when you put a process in place, you will find little kinks in it that there's other methods that you can implement that will make it an easier transition and an easier process to follow overall for all the team and all of the reviewers that we have.
Great input. Let's move on to the next one. As part of a world-class audit program, we should extend the audit plans not only from annual audits or baseline audits, but to also include focused audit for our at-risk areas. Joel, how does UCLA Health Systems identify these at-risk areas, and what types of focus audits does your group perform? Joel, are you there?
Stephanie, can you hear me?
We can hear you now. Yes, we can.
All right, very good, thank you. Well, at UCLA, we conduct focus reviews on all mortalities that occur in-house. We also review all hospice and transplant cases. We audit for the risk, mortality, and severity of illness, so the ROM and SOI scores on the mortality cases to validate whether we have captured all the CCs and MCCs. This helps us concentrate on our observed to expected, or the OE mortality ratio. Here at UCLA, we do a significant number of transplants also. So liver transplants were one of our big hurdles from a denials perspective when we went live with ICD-10, making sure that we had one of the 3 additional ICD-10 codes required for either chronic liver failure, encephalopathy without coma, or encephalopathy with coma. We also are conducting focus reviews on sepsis cases, spinal fusions, and ventilation times, three areas that we seem to have difficulties with. In addition to everything else, our auditors review our records for, they're also looking at the PSIs, the patient safety indicators, and the HACs, the hospital-acquired conditions that may have been missed from our CDI team, and we communicate those findings directly to our quality team.
So it sounds like your auditors are very busy audits happening. You mentioned that you found some denials with some ICD-10 codes with changes that occurred. How were you able to incorporate that audit into your already busy?
Well, that is shifting and identifying hotspots and denials so that we address the denials from either RAC or any other source to accommodate our audit process.
Very good. Thomasina, how does Banner Health identify at-risk areas?
Banner Health, our Ethics and Compliance Department, looks at the OIG work plan to start to see what they've identified on a yearly basis, and our Coding Education and Compliance Department does the same. So we work off of that reports to see we do focused audits on certain levels of service. Observation is one area, incident 2, CPTs, overcoding, undercoding, some rack denials. We will get notification from our department, when they have a rack denial for OBS. We did
Prospectively or retrospectively?
Are you?
To you, Thomasina.
Our audits are done prospectively, and our education and compliance team do prospective audits. Our health does retrospective. We do the prospective in an effort to get the product of the regulatory guidance for reporting whatever service. We go another follow-up audit in like 5 or 10 days to see if the provider has asked what they've been educated. It's a continuation of a process. And then, one that if we see just whoever they'll do a hands-on approach, a one-on-one, we call it shy, there to help them, educate them. So that's how I to make sure that they understand and support their level.
Dr. Myers.
Well, we don't do any of the ODE type things that Dr. Lippen's group does. But what we identify through our audit process when we begin critical care or prolonged care, we will then begin to hold those 5%. Will begin to do readers, frankly, at their expense, so that we can essentially how important it is to correct their documentation habits after education.
Excellent approach of audits of intelligence and coding behavior.
Quick 6 weeks or so because they don't really want to pay for it. And then subsequently they begin to have to pay for it themselves. Their behavior is best when we go out there to educate, we find it rapidly.
That's some great insight. Let's move along to the questions we get in audit services is what the ratio is from auditor to provider or auditor to coder. This has always been a really tough question for us to address because there's different variables or organization. Audit to providers.
Because we are a organization, it varies from, say, our Kentucky physician practice group and our South Carolina and Virginia. Overall, we have a ratio of around 1 certified coder for every 10 physicians or nurse practitioners. In Kentucky, which is a smaller area where we only have around 70 providers, we have 1 or 2 certified coders at any one time. We try to maintain a 1 to 10 ratio. We're in the process right now of reviewing how those internal resources are deployed with the idea that we would like to move to a 1 certified coder for every 7 specialists and then a 1 to 10 for primary care so that we have more certified coding expertise in our specialty practices and then have our primary care physicians share certified coders.
So that seems like a tall order for some of those coders. How do you handle situations where a coder's on extended leave or vacations?
Yeah, that's a good question. And part of our ability to maintain those types of ratios is the fact that our physicians are, in particular, in our electronic medical record, and we are using our coders more frequently on the back end as opposed to coding every single visit. When we do have folks that go on vacation, we have some local cross coverage, and then in dire situations, we do outsource some of our coding, but like I said, at the moment, most of our coding is done in a reactionary type fashion on the back end of the revenue cycle, and we're working toward doing more pre-submission coding through channeling the different encounters in the EMR into work queues so that we can review certain types of services such as level 5 E&M, and then a percentage of other E&M. So we're kind of in flux right now, but our ideal future state is that we can have a little more of that pre-submission auditing by our coders.
Okay, great. Thank you. Dr. Lippin, with UCLA in the hospital organization, obviously the ratio is going to be a little bit different. What is your auditor to coder ratio?
Well, currently we have 3 inpatient auditors, excuse me, that audit our 15 inpatient coders, and we have 1 outpatient auditor auditing 8 outpatient coders. Each month we audit we audit 20 inpatient cases per coder, 30 outpatient ambulatory surgery cases per coder, and 50 ED or emergency department accounts per month. We also currently are bringing on 2 additional coders at this time, so we'll have a total of 6 auditors to enhance our ability to conduct more focused reviews on areas of concern. Ideally, I'd like to get to 9, 6 inpatient and 3 outpatient auditors to do everything we'd like to monitor within our department.
What were the steps that you did to determine what those initial auditor to coder ratios should be?
You know what? We were lucky to find this skill set that we had initially, so we were very happy to start with our first 4, 3 inpatient and 1 outpatient. I didn't do a scientific analysis of that, but it has worked out well for us, and we're continuing to expand.
Excellent. Let's move on to the next question. Deanne, the industry suggests that using a third-party audit organization, why has Bon Secours decided to outsource some of their audit work?
I'd say the main reason is for lack of internal resources. If we use a third-party auditing organization, or Healthicity in this case, that frees up our coders to do some more intense focus training without doing the audit work. So we ask them to do an educational component as well, where they follow up on common denials and a little bit of data analysis from looking at their providers' utilization patterns. So by outsourcing the actual audit, more time in our practices.
Very good. Dr. Myers, it's my understanding that Texas Health also utilizes a third-party audit organization to perform the majority of your audits. Why has your organization gone that direction?
Well, like, Deanne said, it really is about being able to expand and contract based on what our needs are internally. So when we have special things come up, or we get a CMS letter that identifies a potential outlier, we can really focus on that and throw 100 records into the mix, knowing that our third-party auditor can accommodate that. And I also think that from a development standpoint, and really from an overall audit perspective, having someone from the outside helps us maintain true north. And what I mean by that is, we're very embedded with our physicians. We're a physician. We a very tight relationship. I've been with these physicians for going on 9 years now. So I know a lot of them from my education over the years and other things that I do. And so often we become so close and we begin to identify, and it's easy for the audit guidelines to kind of drift, toward the physician. And that's really not good for the physician group. We need to maintain that out in your friend. And yes, I know what you mean as a physician. I can see this encounter the way you see it, but if you haven't documented it, I can't, it's not allowed, not only just by me, but also by a third party that doesn't even know you. And think about what that would look like if CMS was auditing you, or, that type of conversation it helps us maintain true north with our process.
Stephanie, this is Deanne. I agree with Dr. Myers on that. And another reason we like to outsource the auditing function is to keep that separate. Sometimes, I don't know a really nice way to say this, but sometimes it does help our physicians engage with our coders and coding educators if they feel like they are not auditing them or grading them. And it's also, a backup for us that we can show the physicians this is what our industry experts are saying, and that's that agreement with us. So we have that backup from the experts.
Well, that's a great point, Deanne, and I like that, and I agree that sometimes it's an us against them type thing. It makes them bond to us as educators because we can help them as they receive audits and stand with confidence because we've helped them know how to withstand the audit process. And if there's a disagreement, they're now educated to the place where they can advocate for themselves, even though, of course, we're right by their side.
Right, and our takeaway also is that if we are present when the audit results are presented, then that's very helpful for us as well, because occasionally we'll get pushback from a provider that says, that's not what I was told, or, I was told differently. So we try to have that collaboration and make sure it's a team approach.
Excellent insight. Thomasina, it's my understanding that Banner Health also utilizes a third-party audit organization. How do you determine what work you're going to keep in-house versus what work you're going to outsource?
Well, we have a methodology, our audit methodology plan, where we have created internally because our coders don't do the auditing. The coding education, which we have educators/auditors that actually do the education and the auditing. We do prospective, as I mentioned earlier, and we have a certain number that is assigned to each auditor /educator, and they do a number of charts per week per provider, per senior coding manager on the coding operations side. So those ones, the way that we assign it is our external auditors are, and that manager may have several subspecialties and several providers that they manage from a coding perspective. Well, our external auditors allow us to get the rest of them done. It allows us to have a more timely turnaround in respect of the reports, the audit results, creating the education, providing the education, and like that. And we use external vendors right now because our team is relatively new. We were created at Banner in 2014. So currently we have 250 40-some coders. We have about 11 educators / auditors. We are interviewing for 20 more open positions because eventually we want to bring the majority of what our external vendors are doing in-house. Now that's a long-term projection, but that is our goal, is to bring as much as we can back in-house. We work collaboratively with our coding operations team in delivering the education. They're there, we're there. And we always, what helps our providers, I was listening to some of the comments, what helps our providers is when we introduce ourselves, we let them know that this chart review, we don't call it an audit, we call it a chart review, because an audit many times with the provider has a negative overtone, okay? And they walls go up immediately when they hear it. So we call it a chart review, and we say it's for informational and educational purposes only. And we have a 90% accuracy rate that has to be achieved from our team, from our ethics and compliance team. They have 90%, but if they fail to meet that 90% and they're placed on a corrective action plan, then it goes up to 95%. And they do the audit, we do the education, we do the corrective action plan education. So it's all a very structured plan, but our external vendors sting us until we get our team built up to par as we get new candidates in.
That's great. I really stating the audit is a Thomasina, this next question, let's have you address as well. You kind of alluded it to the answer in the previous discussion about outsourcing your audit. So a lot of questions from members about how many audits, how many encountered. What is your threshold for just maybe a baseline audit or an annual audit?
Currently, our baseline is 10 dates of service per provider.
And how often is that? Is that just like annual, the 10 per year?
No, we do. Right now, we have a methodology plan where when a new provider, if it's a new provider, they come on, the coder looks at them, reviews 100%, and then they'll contact us and say, provider so-and-so is ready for his or her initial chart review. We go in, we pick 10 random dates of service, we review it. Yes, the provider has a good understanding of how to document their services, or no, they don't, and these are the and then like 5 to 10 days afterwards, we'll go back in, look at that provider's documentation again, and if there's areas that are still lacking, we do a more intense education. So every time it gets a little more intense, even up to just pulling up each note and going through it piece by piece. We do a lot of our education via PowerPoint with real-time documentation or their chart notes on the actual PowerPoint, but all of the PHI out of it, and the regulatory guidance that is associated with the findings in the chart review. But we do it on initial, quarterly, and annually. That's how we do it for our providers.
Very good. Dr. Myers, does Texas Health generally pull about 10 dates of service per provider per audit?
Yes, that's what we do as well, Stephanie. And I'll tell you, when that really gets difficult is when we're pulling charts for those providers that are both in the hospital setting and in the ambulatory setting. So oftentimes the specialists tend to report, well, I shouldn't say tend, but we see some of our specialists with lots of high-level services, both in the hospital and in the ambulatory setting, and we want to be sure we get the representative samples from both. And if we're only pulling 10, sometimes that's pretty difficult. Like Thomasina's program, we also have an onboarding audit process to give them a baseline, and we do that with once they've been in practice for 90 days with us. That gives us a chance to pull some billing reports. And then we also change the frequency. So once a year we touch every physician or every provider at least once, but based on the score of their audit, they might get touched again. If they score between 80 and 90%, we will internally re-audit in 6 months to make sure they're maintaining and not slipping, that it wasn't just adventitious that we caught them on a steep slide to 50%. So if we can, internally we'll do another audit in 6 months to be sure that they are staying at that 80% level or improving. If they score less than 80%, 79 or less, we re-audit them in 6 weeks after they have received education. So we give them focused education, usually one-on-one. In fact, we require it to be one-on-one if they score 79 or less. And then we re-audit within a 6-week period after that, giving them a chance to respond. And then we put them on the schedule based on their follow-up. If they fail 2 in a row, that becomes an opportunity for them to pay for the audit cost themselves. So that doesn't happen very often anymore. Word's gotten out.
I bet. Thomasina and Dr. Myers, that is great insight on the dates of service to pull. So it sounds like both initially pull about 10 dates of service, but then there's the follow-up audits depending upon their scores. Great information. Let's move on to the next question. Oftentimes, physicians have incomplete or inconsistent documentation. Dr. Lippin, can you describe to us how UCLA handles physician queries to either correct or gain additional information so that the coding can be completed?
Sure, Stephanie. Here at UCLA, we query both concurrently and retrospectively, depending on whether my CDI team reviewed the case or whether it was reviewed and coded by my medical coding staff. We have query templates built into Epic, and our top 5 queries sent out to our physicians in the month of May were for malnutrition, heart failure, altered mental status, sepsis, and renal failure. All of our queries are sent directly to the physicians through Epic, and from a CDI perspective, we currently maintain an 85% coverage percentage of our census. We have a 97% physician response rate and a 90% physician agree rate. The other 15% of the census that's not covered by my CDI team, and then as well as other records, are covered through our medical coding team. In addition, we have a query escalation process where we work with our 3 physician champions. And having 3 physician champions, organizations have been very helpful. It allows for an initial 48-hour response waiting period. And then after that, our queries are escalated to either my CDI manager or my coding manager for resolution. If none of that is successful, we get our physician champion involved to approach the appropriate physician to elicit a response. If none of that works, we also have built into our plan that we would send the query up and escalate it to the department chair and CC the system CMO. Luckily, we haven't gotten to that extreme yet, at least not at this point.
I like that input to have 3 physician champions. Now, do they spend a lot of extra time helping to support obtaining those responses, or is it fairly limited?
They do a lot of different things. One of our physician champions does a lot of work with informatics and churning numbers. Another one does work with educating physicians on specific topics. And then the third one deals with our query escalation process. And so they trade off, but mostly that's how it pans out.
That's a great use to ensure that we're getting those responses back that we need. Thomasina, does Banner Health have a query process in place?
Yes, they do. I know from the acute care side, they actually have developed standardized queries for like sepsis, and I know sepsis is one of them. I can't really speak strongly to that because I work mostly on the professional fee side. But for the professional fee side, there are codes that are in the EPM part of NextGen they have right now. Code has a clarification or query that's sent back to the provider. The claim is placed on hold, and then the coders will send it via email, or in NextGen there's a task where you can send, it's almost like an email, but it's within the EMR that you can send back to the provider for clarification, and that's how they do their process. But currently we have, in the near future, we have thoughts of creating some standardized queries that we're hoping can be implemented into the Cerner EMR that we currently are rolling out Banner Health system-wide, that will be standard for the professional fee coders to send to the provider for different clarifications that are needed in the medical record.
Yes, anytime you can utilize technology to be more efficient with your processes, that's great. Deanne, describe to me how you handle situations where there's a coder or auditor has queried a physician and either you're not getting a response or you're not getting the support that you need.
Oh, Steph, that never happens, right?
Right.
Well, we do have those challenges. Being in an ambulatory setting, we don't have a CDI team, which I'm so jealous. We do in our acute care settings. But the physician. But when we have that non-response, we get the leadership. If we have COOs, chief operating officers, and then we haven't received a durable amount of time, we bring in the operational leadership or the folks that can have a performance management than we can, and we get a lot of support from them. So we're really fortunate that they understand, you know, that we have just so they and if you know every once in a blue moon we may get the physician CEO
And then we choose Thomasina that mentioned that we focus our reviews based on RAC and other denials. But
Great, thank you. Let's go ahead and address some of the organization use auditors that have the CPMA certification.
Yes, thank you. We do. So we think the CPMA and credential to have the CEMC, I believe, is also really valuable. I've got that one, but E&M auditing is, in my mind, a really specialized niche, and utilizing someone that has a really complete, robust background in evaluation and management and CPMA auditing in general is a big thing for us, both from the skill set and from the credibility perspective. So I would think that both of those would be really very important for your auditors.
Great. Next question. What tool did the last panelist use to track data for audits? So I'm not sure which panelist that was. I'm not sure when the question came in. So let's read that again. What tool is used to track data for audits? So I'm thinking maybe an automated tool or program or something like that.
Well, Stephanie, I mentioned software that we use here at UCLA. Our CDI team uses a software called Declaro CDR squared for CDI, and we do all of our auditing and tracking through that. And then from a medical coding perspective, we use the PricewaterhouseCoopers SMART software, and that's very comprehensive as well.
Very cool.
We're also looking to move towards the 3M360 Encompass computer-assisted coding, which will alleviate the need for the Claro Group tool.
Okay, great. Next question, how many audits can physicians fail before they're billed for the audit? Dr. Myers, can you address that?
Yes, our policy says that if they fail 2 consecutive audits, that they are now responsible for the audit cost, and we estimated audit cost based on how much it costs us to actually send the records out to our third party, and also the physician time or the educator time, and in our case we use me as a physician to do those. So it's a fairly steep cost that is, we have an up to type language in our policy, so it's up to approximately $3,000 for the audit cost. So it gives us a bit of leeway in how we decide we want to charge the physician, so or to charge the provider for those failed audits. Generally, we give them some leeway. So if they're making improvement from audit 1 to audit 2, and they show engagement in the process, we'll give them another audit and sometimes even a 4th one, fully acknowledging that they are in the, they're kind of in the hole with us. So then at a certain point when they either fail to improve or really aren't engaged in the process, we have them we put them on prepay audit at their expense.
So you do work with the physicians. That's good to hear.
Yeah, well, it's hard not to, and sometimes there's compelling reasons for what happens. And honestly, one of our biggest challenges with with auditing is the physicians that are new on Epic. That's our integrated medical record, and sometimes they're in order to get faster, they are utilizing shortcuts that really do impair their ability to have a codable note, and so that sometimes is a really big challenge. And then often or other times it's the bad habits they had before they went on the electronic record that are just amplified by going on.
Okay, great. Let's go on to another question. How do you conduct an education to your physicians? Is it one-on-one? Is it with a group? And how do you schedule it with the physician's busy schedule? Thomasina, would you mind taking that question?
I'd like to input too.
Not at all. I'm sorry.
Thomasina, go ahead, and then we'll circle back to you, Dr. Myers.
Okay. When we schedule our educations with our providers, we do them one-on-one and by group. If it is an annual education, it is for the group. We do our annual specialty education Banner Health-wide, and we have them like February and March are our pediatric months. So all of our pediatric specialties will receive annual education, and then we begin with our adults, and each specialty or two specialties will have an assigned month. We reach out to the practice managers and notify them of, this is the month for the, say, urology education. This is the date and time, and we send those out, and then the providers will join. If we have a process where we do one-on-one education, where we're targeting more specifically an individual provider that needs additional education, or if it's for our direct-to-bill process, we do one-on-one educations as well. If we get a request for an ad hoc, it's one-on-one. So we do a variety. It depends on the type of education, the need, and the request. So it can go either way. But we do a lot of one-on-one. We find those to be more effective.
Great. Dr. Myers, did you have... Excuse me, great. Dr. Myers, did you have anything else to add?
Yeah, so I just wanted to say, I agree, you do a lot of ad hoc, and when people ask for it, you do, especially if they ask for it, you absolutely want to honor that request. We also do monthly new provider orientation with about an hour and a half of coding and documentation education for any new provider that comes to the organization. So we have those on the third Tuesday of every month, and then monthly we go out to the different zones. We cover 16 counties in north central Texas, and some of them are quite a distance apart. So we travel to the different regions and have a monthly program on the first Wednesday night of each month. And we thought 2 or 3 years ago, actually 3 years ago now when we started this, that it would really taper off and everybody would quit coming. They seem to come over and over again to these monthly programs so we set them a year in advance so all the different areas know when they are, and they either assign providers to them or the providers come on their own. Of course, we require some type of education if they score between 80 and 90%, and often they choose to do that group education program. And for any provider that comes to that group education, I have their audits with me so that we can go over individual audit findings during the time of that education. And then we do one-on-one for everybody that scores less than 80%. We also have a web-based program. Similar. Yeah, we have a web-based program for incident too that we require all of our physicians and mid-levels to see when they join the program. And we do it for all of our physicians in case they add an APP, but we also require it for all those practices that have APPs coming in.
Very good. All right, let's go on to another question. As best practices, should physicians document critical care start and end times? Deanne, would you like to tackle this one?
Sure, can you repeat that, please?
Sure. As best practices, should physicians document critical care start and end times?
I would love for them to. I have not been educating that they absolutely have to, but I think that would be a best practice in my mind.
I agree, Stephanie. And what we find is that multiple specialties doing critical care, if we can get start and stop times, that helps us in our appeal process if we get some denied.
That's an excellent way to describe it, and so I'm going to borrow that for my conversation. Thank you.
I've written down several things that I'm borrowing from everybody too.
I know I'm taking a lot of notes, so thank you all.
Okay, we have time for one more question. What suggestions would the panelists have for a coder in charge of auditing a multi-specialty practice? Currently, the audit process is in its infancy and just getting off the ground. Thomasina, what are your thoughts on this one?
Well, my thoughts on this is for the coder to become well-versed in regulatory guidance and documentation requirements for each specialty. I don't know what type of specialty it is, if they do procedures in addition to E&Ms, you know, and being able to deliver the education in a manner that targets the areas where it's needed the most. Develop a strategic audit methodology plan that will cover all of the areas, identify risk areas, and tweak it as you go, because you're going to have to tweak it, especially since it's in its infancy stage. It's going to require some changes that are going to have to be made, I assume, along the way.
We broke it into specialty groups so that we had, you know, we have one group that covers cardiovascular and oncology, and another that covers ortho and neuro.
Right.
So that we would be able to kind of get some specialists in those groups. And we started with certain codes in the hospital so that we could kind of get a handle on the hospital side, and then we expanded into the high-level codes in the ambulatory side. So we actually started with people who had some knowledge of particular specialties and started with certain codes so that we could get a rhythm going. And then once we began to realize a return on that, we were able to expand into other services.
Great input, thank you. Unfortunately, we're out of time. I'm going to turn it over to Patrick.
Okay, thank you to our presenters. It was a fantastic presentation today. I want to thank everybody for attending the webinar today. I just launched a poll. If you could give us some feedback, we're always trying to improve our webinar processes. We hope you all enjoyed this. If you have any other additional questions, please email them directly to at healthicity.com, and we will also be emailing everybody in the next few business days with an on-demand recording of today's presentation, as well as a link to the slide deck where you can download it. So keep an eye out for that email, and we will also be addressing additional questions in our blog post series. So if you aren't subscribed to our blog, please go to our website and do so. And thank you again for joining. Have a great day.
Thank you for having us. Have a great day.